By way of introduction to the analyses themselves, or the data I want to show you, I want to mention a few unique features of children's health that are worth keeping in mind as we go through the argument. Again, this will be familiar to all of you. Now that I've sat here all morning, I realize that the same issues are brought up in many different ways. But you're comfortable with the idea that children are vulnerable, that they have to be protected, that they don't look after themselves, that it's somewhat our moral obligation to look after them, that they're dependent not only on their parents, their schools, their communities, but also on society, that health and development are linked. I think that's the point that was made during the noon hour, and that unhealthy children can't learn. Finally, the argument about demography has also been made this morning, that we're an aging society, children become a smaller proportion of the overall society, they command fewer resources, and all of that is an issue in developing an approach to early investment. The piece that hasn't been mentioned this morning that I want to just mention briefly is the notion that what happens to us early in our life has implications for health across the entire lifespan. So some of you may have seen this Newsweek magazine or know the work of David Barker and all the work that he stimulated about how early influences on life, even in utero, may not have their consequences or may show up 5 and 6 decades later as cardiovascular disease, type 2 diabetes, stroke, and so forth. Another unique feature of children's health that I want to bring to your attention is the idea of multiple determinants. Our usual idea that as adults we're responsible for our own health. We make choices about lifestyle that influence our immediate health and have consequences for our health. But in childhood we have to be thinking not only about those lifestyle choices but also the interaction between the genetic, the biological, the social, the environments, all the different kinds of environments that children live in, and then all the different healthcare systems and other systems that affect their ultimate health outcomes. So the model that we use in thinking about this work is one that includes all of these determinants. Finally, the unique feature of children's health is that we define children's health somewhat differently than we do adult health. Children's health, of course, includes health status and reducing disparities. We're comfortable with those kinds of definitions. But you could also argue that children aren't healthy unless they're living in a safe environment. That the kind of behaviors that are shaped early on don't have a lot of implications for their health early on, but that they may shape a lifetime of lifestyle choices and behavioral choices which will have big effects on their ultimate health. Children and their parents are educated early on to be better healthcare consumers, so that ultimately influences their health. And then finally, there is a group of children, maybe 10 to 15%, who have serious health problems that are expensive, that bring them into the complicated medical system where they access lots of different kinds of services. And we don't want to separate them out. We want to continue to think about their needs as part of overall child health needs. So those are some unique features. And then we went on to ask the question, well, how should we go about investing in children's health? I think you're comfortable again with these ideas that early investments have lifelong consequences and costs, that we want to focus on prevention that actually is capable of influencing the outcomes, this concept of turning the curve from the management literature. Investments need to address the multiple determinants. Often we see in interventions that only address one cause, and then we're disappointed that we haven't had much of an impact on an overall health problem. An important thing with children is that since children live in schools and communities and different environments, and often they depend on those different systems, that the implications of one system has an important effect on the others, so that we want to integrate the public health, the educational, the medical to optimize children's health. So with those kind of background ideas in mind, we wanted to look at 3 examples that we'll use as cases in this presentation. We want to spend most of our time talking about tobacco and child health. We'll also talk about obesity, and finally mention something about injury and its importance in children's health. We're going to review a little bit about prevalence and talk a bit about these conditions. We will say something about the cost implications of them, and finally look at some interventions and their impacts. So the first one is tobacco and child health. The data is best here. There's good evidence now that children are exposed to tobacco in multiple settings, prenatally when their mothers smoke, in their home through environmental exposure, and as teens who begin to smoke. The direct medical costs of pediatric exposure to tobacco is now well documented, and that $7.9 billion in adjusted to 2006 dollars are attributable to parental smoking and all the different consequences of parental smoking. So we're talking about a low birth weight that results from mothers smoking in pregnancy, asthma, sudden infant death syndrome, otitis media, burns, a large number of conditions that are directly connected with parental smoking. And we estimated that you could save $1 billion in direct medical costs with a 15% reduction in parental smoking. We've developed this figure to kind of demonstrate where we think there are now interventions that will impact both children's health and ultimately adult health. So the way to look at this figure is across the top we've identified preconception, pregnancy period, infancy, adolescence, and adulthood. And then down the left side, we look at where interventions could take place. They could be at the individual level, the way pediatricians might do it in their office, in the family, through home programs in the home, in schools and communities, and then at a national level. And what we've tried to do is look, and doing these horizontal bars, we've tried to indicate, well, where is there evidence that intervention in early childhood or in infancy or during pregnancy would have an effect, and is there evidence that that effect goes out across the lifespan? So the way to look at this chart is there's clearly now evidence that smoking cessation, whether it's in pregnancy or in adolescence or adulthood, has benefits across the entire lifespan. That we now have programs that are demonstrated to work in doing smoking cessation for adults who have children in the home. We have interventions at the community and school level, for example, increasing sales tax or media campaigns or other community-based programs which will reduce teen smoking and ultimately have impacts across the lifespan. And finally, we're now seeing, for example, in New York City, that there are bans on smoking which seem to be effective and, again, which have implications over the long term. One caveat that I should mention is that even reviewing this large literature, there are many gaps in the literature, so that for every one of these studies, there isn't always evidence that's followed the population out into adulthood and really documented what are those long-term effects.